Good morning, everybody. Gabriele Jasper, interventional pain physician, MD,
That's right.
and with Jeremy Vickers,
Hey guys, how
my
you doing?
co-host here with Painless with Dr. Jasper. Listen, if you can't hear me, please get back to us right away.
Yeah,
And let us
text
know.
us.
Sometimes we have a technical problem where you can't hear.
Yeah, I'm gonna write "We are live." You can text right underneath that, and let us know.
All right. So here I am, an interventional pain physician, which is everybody has their own definition of interventional pain. You have maybe today we should talk about the different subspecialties,
That'd be
which
great.
I like to talk about.
Yeah.
And when I say interventional pain, I mean by origin, I guess our base would be called pain doctor. Pain management, but it isn't considered pain management anymore when you're an interventional pain physician.
Yeah.
Some of the patients come into the office and they don't understand that exactly what I do. But it's somebody especially an interventional pain physician, we work mostly on the spine.
Mm.
And what do? We try to find out where the pain generator is, and the pain generator is what's causing you to have the pain. And the problem with any kind of pain, especially from the spine, you can have multiple pain generators causing the same pain. I beat this to death all the time. You just have to understand this concept, and some patients just don't understand
Right.
it. Sometimes I'm questioned: are you an orthopedic spine surgeon, or are you a neurospine surgeon? I'm neither.
Right.
I don't pretend to be either. They have their own specialty. They have their own fellowship training. We have our own specialty. We have our own fellowship training. And it depends on when you actually graduated. Looking at my face, you could tell I didn't graduate yesterday. It's been a long time since I've been practicing. I've been practicing, pushing 30 years now.
Yeah.
And especially when it's more than 30 years that I've started my that I've been a physician, and I've been, studying as a physician, not only studying as an MD, but learning new concepts, new techniques. And a true, and now most of this is my opinion. A true interventional pain physician is somebody who goes out there and learns the new technology.
Actually, yeah.
This is my definition. Somebody else could have a different definition. But somebody like myself who goes out there and learns a new technology to make people better using minimally invasive stuff or non-invasive procedures to get the same job done or better than doing major spine surgery.
Right.
That's what my goal is. That's my conquest. This is what I need to do for my patients.
Right.
And I set my whole career around that, avoiding major spine surgeries. Now, and I always say it, the next breath I say, when somebody really needs spine surgery, they really need it. And I'm the first one to tell you.
Mm.
But we do a pretty good job of avoiding it.
Yeah.
Because of the new technology and the new techniques, the new instrumentations that come out. There's always somebody down there, as a joke, I say, in their basement trying to figure out how to make these things better.
Right.
And whether they're physicians, scientists, or
God bless them
engineers,
for it.
They do it to help people, and that's what I do.
And we've actually, over the last couple of years, we've actually seen some amazing innovations in the technologies you already use. Like just better and work better for your patients.
Yeah, at one point, when I thought endoscopic surgery was the best thing in the world, and I've mastered it, it has been replaced.
Right.
Not completely, but it's being replaced with easier, less invasive, and believe me, endoscopic surgery there's really nothing more less invasive than that.
Yeah. Yeah.
But when I say less invasive, you're targeting endoscopic surgery. You target one area. Now, there's different parts of the spine where you can target, but you can't target it all at the same time. It almost becomes separate surgeries for different things.
Right.
Whereas, for example, the interspinal spacers, they kill 3 or 4 birds at the same time. They open up the they open up the center canal by lifting the posterior part of the spine,
Hmm.
and they also decompress the joints by lifting the posterior part of the spine. Have you noticed that when you put the interspinal spacers in here, what happens is it opens up the neuroforamina where the nerve comes out. Whereas endoscopic surgery, which I love, um, you have to do that individually. If you got to open up this hole, you go in and open up that hole. If you have to open up the posterior part of the spine, you got to go in there separately and open up a posterior spine. Now, if you got to go to the other side, you got a completely separate procedure.
Hmm.
Now, do you do it all at the same time? Some people may do it all at the same time. It becomes very time consuming and not cost effective. And you're doing more trauma, which is not much to the patient than you have to in one sitting. It's more anesthesia. At that point, you're better off doing it one at a time because a lot of times you could help other parts that I tell you can do separately
Mm.
by decompressing the center of the spine. You're helping. You're making more room. So ultimately, that might be all you need.
Right.
So that's just an example. I was questioned this week about what were you saying?
Well, I was going to say you once on the show you came up with this amazing analogy about pain generators, and I think you said think of a symphony, right?
Well, yeah, I always tell. Well, that reminds me of a patient
Yeah.
came into this week with his daughter, and it's she was very concerned about her father. Really has no clue of how my practice works, and not too many people do.
No,
You know,
they think pain management, and that's it.
yeah,
Yeah.
they think that it's you get one shot and you're
Mm.
going to be good, and if it doesn't work, you're no good. You don't know what you're doing.
Right.
Well, it's not true. Uh, you got to compare yourself to what surgeons do. Surgeons, they do certain diagnostics, probably not really procedures. They do diagnostic tests the same as we do. Do a history and physical examination. Physical examination points in certain directions to make a diagnosis of what's actually causing the pain.
Right.
However, like I said, you can have 5 pain generators during that physical examination that are popping their heads out of the hole. And you still got to figure out which one it is. So you look at the MRI, and when you look at the MRI, you come up with a closer idea of what could be causing the pain.
Mm.
Now, if somebody comes in with severe leg pain, you pretty much know that one of the nerves coming out of the spine has pressure on it, causing you a sciatica type pain, right?
Hmm.
So that you can narrow down based on the history. But now, when you get straight back pain could be a pinched nerve in the upper portion of the back. Like 1, 2, or 2, 3.
Yep.
2, 3 can cause you to have hip pain, so you got to do the differential diagnosis with a bad hip.
Mm.
But you need to do certain things besides just looking at objective findings and subjective finding, which means objective means looking at the MRI, X-rays. Subjective means well, who's that?
No, it's your phone. Your phone.
Subjective means looking at the patient on their physical examination, the way they feel. But a good interventional pain physician does what they call diagnostic injections.
Yeah.
Right? If you have low back pain and you have intermittent neurogenic claudication, which means that you walk a certain distance, you get pain in the lower back into the buttocks area, you sit down, it hurts, and then you sit down, it feels better.
Mm.
That's neurogenic intermittent claudication. Now, what you got to distinguish that from also vascular disease too. There's so many different ways, so many different pain generators cause the same thing. I keep saying this. People don't understand this. It's not one shot, one deal. You're done. But so in order to figure these things out, you could have arthritis, you have a pinched nerve, you got spinal stenosis, you could have discogenic pain, which means that the disc actually hurts, or you could have pain from inflammation of the nerve inside the bone of the vertebral body.
Right.
Right. That's called vertebrogenic pain. I just named at least 5 or 6 different pain generations that cause low back pain. So what do? You got to start treating them.
Mm.
Now, I have my own protocol. If somebody has frank spinal stenosis, I don't care what you do to them, and they got the symptoms of it, and they got the objective on the MRI, you got to treat that first. If you don't treat that first, you're not going to get any results, any positive results. Once in a while, I get a patient that has a borderline central canal stenosis. And when I got a borderline central canal stenosis, you look at it and say, this guy's he's got clinical signs, symptoms of central canal stenosis. He's got that I can't walk far, I can't stand up, I sit down, I feel good. I lean on the shopping cart. But you look at the spine, and they got mild, maybe. Most of these that are confusing have mild and borderline moderate, but mostly mild. But I've learned over the past years that you can have somebody with mild spinal stenosis and have severe symptoms of spinal stenosis. But what do? You can't just, it's hard to treat these type of people. To stick, make an incision, which is not much. It's a 5-10 minute procedure. You make an incision, you put a spacer in between to open up the central canal. You put a spacer in, spacer stays here, right? I don't have a spacer. We should bring one in.
Yeah.
But you put a spacer in there, and all of those symptoms or majority of symptoms go away, especially when you get every level. But this particular patient had mild spinal stenosis with symptoms of spinal stenosis. And he just wasn't responding for some reason to any of the injections I gave him. You give him an injection like around the level with a spinal stenosis, probably 99% of the patients feel fantastic. Could be for 2 hours, could be 3 days, it could be six months.
Right.
Usually not more than 6 months if they have spinal stenosis, depending how severe it is. But it's not the severity you see on the MRI. I've had people where it's almost obliterated, and they're walking like it's normal. I don't know how they do it, but you got to treat each patient individually. So he was difficult. I did on this patient. First I did the transfemoral epidural on the level that had the worst spinal stenosis, which wasn't that bad because of his symptoms, not because of what I saw on the MRI. But he had severe arthritis, spondylosis, they call it, in the facet joints, which are these joints back here, those 2 joints, from the base of the spine all the way up to around the thoracic area, somewhere in the thoracic area. So it was all the lumbar vertebrae. That can cause you to have the pain that this guy had. If it's bad enough, you can't walk far, even with arthritis, and you sit down, it usually feels better. If you sit down too long, you get up, you're like, really hurts. Whereas with spinal stenosis, you sit down, you stand up, doesn't really hurt until you stand for a period of time. So these are all, or walk. I mean, and you got to make the diagnosis. So
I used to say, oh, now my back's settled, and like get it back up. Oh God, that's
well, that's arthritis.
Yeah.
But so I treated him. I gave him the injections, the epidural, and he just had I don't know whether it was him or he didn't understand. He seemed like he wasn't stupid. He seemed like a normal guy. And by the way, he was a guy that didn't do any physical activity all his life. It wasn't like he was a construction worker, and his back was bad.
Wow.
His back was bad. It's genetics. So I gave him that shot, and then usually you get 100% pain-free right after. He didn't even get 100% pain-free, maybe 30%. So that throws you off right there.
Right.
And he comes back 3 weeks later. He says, it lasted, that 30%, whatever it was, lasted until I got home, which that could happen with spinal stenosis. So you can't completely rule spinal stenosis out. But what am I going to do? Make a diagnosis that it's spinal stenosis by making an incision and putting a spacer in? No. It's not that obvious yet. We got the first thing in the Hippocratic oath is non nocere, which means do not cause harm. And you got to do the least invasive stuff first. So this guy happens to be one of those guys. It's a process of elimination. I hate to say it.
Yeah, you gotta know when to do it and when not to do it.
Yeah, it's a process of elimination. So I said, you know what? He's got bad arthritis. Let me treat his arthritis. So I treated his arthritis on the lower levels, and it seemed to get a little bit better. Not much, but he has it going all the way up. So I treated it going all the way up. And he still didn't get any better. Now, this guy's received now, he's my patient for a couple months now, and seems like nothing's working on him. And I'm just starting to say, he does have bad degenerative disc disease. I was considering maybe doing
Viadisc.
the Viadisc.
Yeah.
But now, insult to injury here, he's got shitty insurance.
Right.
He's got a disadvantage plan, which I don't want to open up a whole new can of worms here today.
Right.
He's got that Medicare Advantage that doesn't pay for spacers. So that's another reason I didn't have incentive to put spacers in, because they're expensive to put in and his insurance won't pay for it.
Yeah.
Now he's got the other pain generator, which is degenerative disc disease, and we replaced the nucleus. We replaced the nucleus with an allograft, and I've been getting tremendous results, good results with it. I can't even do that. And these are, minor stuff that you can do on these patients and get tremendous results. So
they tie your hands.
Yeah. So at this point, I reached crossroads. Like I did the stuff that I'm allowed to do on him as per the stupid insurance. And then he shows up the other day with his daughter, who was like, she came locked and loaded, man.
Oh boy.
Locked and loaded, man. She was not a happy camper. And I'm not going to go into detail what she said, but certain things, like, for example, questioning my credentials. Why are you giving my father shots if none of them were working? And then I tried to explain to her that they're diagnostic injections.
Tools,
and I treat, and I went into the whole thing. Why doesn't everybody else do the procedures that you do? That obviously our father can't have done, because unless he changes the insurance. That was going to be the discussion that day, was to see if we get him to change the insurance, because at that point I was considering treating which I do. I get to that point with somebody with such mild central canal stenosis, and they just have obvious symptoms of it, because nothing else worked, and we eliminated everything else. It's time to put a spacer in, and that's what it came down to. And I can't do it unless you change insurance. That was going to be the discussion.
Right.
I tried to explain that to her, and she goes, "Why don't they pay for us?" I had to explain. I was with her for like an hour. He's just sitting there like a mope. Right. And so
he doesn't even have a voice. She's his voice.
Yeah, because she's pissed that nothing's happening. She has no clue. And I went to the point I had the visual aids. I had the MRI. I explained through visual aids what his diagnosis was. Everyone. In fact, remember that talk we gave one time talking about the root of all evil is we did almost a whole show on degenerative disc disease causes this, that. I did all of that for her.
Yeah, and all the different little things all around that could happen there.
Problems. I did that for her. And then she and I said, well, it's based on, his pathology. She goes, I don't even know what pathology means.
And what are you arguing about?
No, the thing is, I explain what pathology means.
Yeah. And
then she's saying, let me ask you a question. Are you a neurospine surgeon or orthopedic spine surgeon? I said, neither. She goes, well, then what are you? And this is part of today's conversation, the different subspecialties. And I told her, I said, listen, I graduated medical school. I'm an MD. I did a preliminary residency in general surgery, right, which is the base of any kind of surgery. From there, I went into anesthesia, because I liked anesthesia, and I knew anesthesia was at the time, I'm pretty sure that was the only subspecialty that had pain. Later on, physiatry came out and everything else. It might have been just starting the physiatry pain fellowship programs. And then from there, I which was rudimentary in those days.
Just correct me if, just for my own information, you did work anesthesia for children, right?
Yeah, that had nothing to do with this.
No, I'm just curious about it.
But and then I explained to her that since the last 18 to 20 years that I've been doing it, I've gone to it's constantly evolving, getting better and better. And this is how I can help your father. That the new procedures that come out, and I constantly learn it. I don't let any stone grow, I learn everything that you could possibly learn.
Yeah.
That helps patients. That's legit.
No moss grows on you.
And she just, she goes, well, I'm going to bring him to University of Pennsylvania to get a second opinion. I said, well, I wish you would. I wish you would do that. And I said, but you're going to have two different types of surgeons. You're going to have a surgeon that is going to look at his spine and say, listen. I said, first I asked her, I said, did you go to a surgeon yet? This is before she told me about it. She goes, no, I've never seen a surgeon, orthopedic neurospine. So, okay. And then she told me she was going to go. I said, we can have two different surgeons. The first one's going to tell you, look at his spine and say, you know what? His spine is so bad. He's sitting there comfortably. He walks, maybe 100, 150 feet. Then he's got to sit down. Or if he leans on something, he can continue to walk. So the quality of life is not tremendously bad. If he has pain, he sits down, he feels good. I don't want to operate on this patient because he's got such a bad back. I could ruin his life. It's too much. I have to operate on every level, maybe 6 levels because he goes into the thoracic spine. And she goes, you know what? I did go see a surgeon at Rothman Institute, and they told us the same thing. I said, well, then you have it. Then you have it. I said, you told me you didn't see one, and I was, but now you're saying you did, but that's okay. Maybe you forgot.
Yeah.
But let me tell you, the other type of surgeon might be somebody who's very aggressive and in their heart think that they could actually help them. I'm not saying they do it for the money, because nobody will do stuff like that for the money. I don't think. I just hope not. If they know that it's going to be a bad outcome. But what's going to happen is you ask him, what's the success rate? It's not that high. And what's the chances of him getting worse? It's very high. And that's what it comes down to. I said, he, as far as I'm concerned, does not need major spine surgery because his back is perfectly stable, proven by flexion extension films and everything like that. We could prove that easily. But she goes, well, how do you do it compared to the surgeon? I said, well, the surgeons treat most of the time, treat what they think is will get rid of all their pain. If they got 5 bad levels, they'll do 5 bad levels, most of them, unless they could do their own epidurals and stuff like that to isolate which one's the worst levels, or rely on a good interventional pain doctor to tell them which ones are worse by doing these diagnostics. I said, I do one pain generator at a time. And with his case, it's a little tougher because he doesn't have severe spinal stenosis or even moderate.
Mm-hmm.
But in my brain right now, I'm thinking he's getting affected tremendously by that mild, the mild spinal stenosis and what he needs to do as far as changing his insurance. And I said, I do this, and this, and this. And she goes, well, why isn't everybody else doing that? And I said, well, and I went into a whole big story about the politics of it, on how, the hospitals make tremendous money on spine surgery. The industry that sells it makes it. The surgeons make a lot of money, and it's a hard thing to get rid of. And it's mostly the hospitals in the industry, maybe not necessarily the surgeons, and they got strong lobbyists to keep it going. And that's my opinion.
Mm-hmm.
And it's proven. But anyway, and then I say do one at a time because we figure it out. Then we finally fix the pain generator and patients do well without major spine surgery. She goes, oh, I understand what you do now. The surgeons make a lot of money all at once, and you, little bit at a time, you're making probably more money than the surgeon's making by doing all of these cases. I said, what do you insinuate?
Why do they always bring it down to money?
Well, it has nothing to do with money.
Yeah.
I said, I don't know how much I make when I do these cases. I treat people, I have people in my office that take care of the business part of it. I said, I got a clear head. I look at patients and I try to figure it out. That's my job. The only problem is when it comes to money, if they have bad insurance, I can't do certain things that I know will help them. Right. And she goes, no, I understand now how it is. Really nasty. And I said, what do you insinuate? You know what I'm insinuating.
Yeah.
At that point, I had to ask them to leave. And I discharged them as a patient. Very politely, I did it. And she's swearing as she's going out, saying he's an ignorant, unprofessional, typical Italian.
Oh, that's racist.
She brought up my nationality.
Wow.
How does she even know what my nationality is? I guess it's very clear.
I guess you all look alike.
Yeah. But she's cursing the Italians out, walking out. That wasn't even part of anything of the subject.
Really? So she had a rock up her ass before she even walked in, and the result was always going to be that, her storming out, flipping everybody off.
You know, not to be negative, because I had strict orders this morning not to be negative.
Right.
But it's just things that happen in our practice. You know, it kind of blows for a short period of time. I get over things pretty easily.
Mm-hmm.
But it kind of blows the wind out of your sails a little bit, you know?
Yeah.
And I told her, I said, listen, I have 50 patients today, or close to 50 patients today, that adore me, they love me, and they appreciate what I do for them because I help them.
Mm.
Right? And I know in my heart that I can help your father. I said, too bad this had to come to an end like this. And I walked away. And then the rest of the day was beautiful. The patients people were doing great. Some people were getting a little bit better.
Yeah.
I appreciate the fact that you don't do, you do just stuff that you think that I need.
Yeah.
You know, I mean, it's exactly, and they understand. Some of the people understand, or most of them understand my methodology on how to treat pain, chronic pain with multiple pain generators. Eventually we get them. So that's the story of the week, but we got a lot of good stories of the week. I mean, I did yesterday, for example, not yesterday, Thursday, we did like 3-minute man. We didn't do endoscopic. We did that on Tuesday. We did 3-minute man procedures with just spacers, and they all did well. And we did also intercept procedure, basal vertebral nerve. We ablated that, which got rid of the patient's. It was actually, we did 2 levels on them before, and they were 50%. We did that, and they got right off the table with no more pain in their back. And we did some Viadisc, which, we put the allograft in the center of the disc.
Yeah.
It was a great day. And we did a bunch of diagnostic injections and therapeutic injections. It was good.
Well, I got here, it's too much to put up on the screen. So, you are a miracle working doctor and physician. This is from Christopher Cullen, who has twice now fixed my lower back and stenosis pain for 3 years now after 2 procedures. And I praise your expertise and your patience in expertly handling and keeping patients from having to have major orthopedic surgery. God bless you. And I am grateful to call you my lifetime friend and best doctor in America. Happy Thanksgiving to you, and wishing you a most healthy upcoming holiday season. You are so positive, and thank you for being you, exceptional in every aspect of your being.
Chris, you're going to make me cry here.
That
on international.
I got to tell you
podcast.
something. That was
Thank
beautiful.
you very much.
That was beautiful. You can't get a better compliment than that.
He's a great guy, and
Yeah.
he's got a bad back,
Right.
but a little bit easier to figure out than like that other gentleman that I had. You know, when you got everything's bad, and he doesn't have everything bad.
Right.
A few things, few injections, and he does well. Plus, he's a different kind of person, Chris. I mean, he appreciates it, and he has a positive affect in life. And when you're positive like that, you do good no matter what.
We got another one here. You ready?
Yeah.
Yeah. This is from Eileen Anderson. She says, "Good morning, Dr. Jasper. Eileen Kirk here. I want you to know I am feeling great since my procedure on Thursday. I want you to know how grateful I am that you have never given up on me and have worked so hard to make me pain-free. I love all of you there at the Jasper Spine Institute who treat me so well with dignity and respect. Happy Thanksgiving."
Well, thank you very much, both of you. Happy Thanksgiving and holidays. And I you don't understand how good that makes me feel. And 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 that goes back to what I said to the patient. I said, I'm going to have like another 40, 50 patients today that appreciate what I do for them.
Yeah.
And I told her, I said to the lady, I said, there was no reason in the world why I should stand here and put up with this kind of abuse. You know,
No.
I don't need it in my life now. Nobody ever needs it, but I'm to a point in my at a point in my career where I eliminate the riffraff.
Right.
You know,
You got to make time for the people who really want it.
That's just an
Yeah.
expression. Eliminate the riffraff. They might not be riffraff,
Yeah.
but eliminate the pain in the ass people.
It could be hooligans.
Yeah, who the hell? I do not need that.
Yeah.
Most people at my age, most doctors at my age are retired.
Mm-hmm.
Especially, the old days they never retired, but now doctors are retiring at 60. Before 65. I'm 69 years old, and I have no intentions on retiring. But you get somebody like that, you say to yourself, "What am I doing this for?" But then
you may be 69 years old, but really, you're like a 52-year-old guy.
Yeah. Well,
yeah.
Thank you very much.
Let's be honest. Yeah. You can outrun me. So yeah.
But then I get that short spurts of insanity saying, who needs this shit?
You do.
And then all of a sudden the next 10 patients are beautiful people like them, and
some people can bring it down just like that. That woman walking in, she already had an ulterior motive. She wanted to go, she wanted to scream, make herself look like a big shot in front of her dad. I'm going to take care of this, and I'm going to get rid of this guy. It was always going to end up how it is.
She already came in, like you said, thinking that I was taking advantage of her father and doing injections that didn't work just to make money.
Yeah. It's like asking a random guy in the street, where do you work? Oh, I make sandwiches at Wawa. Oh, so you make sandwiches and then you collect a check, do you? I see what you're doing. I know what you're up to here. It makes no effing sense. Hey,
listen, we all got to work. It would have been nice to be born, independently wealthy.
Yeah.
But if I was born independently wealthy, I'd probably do stuff like, invest the money and enjoy taking money and making money. Make your money make money for you. That's probably a pretty interesting career.
Yeah.
There's a lot of entrepreneurs that do that. They don't work. They make the money work for you. No, I'm a hardworking guy. I don't really have any investments. I joke around and say I have all my money invested in depreciating toys.
Yeah.
And that's the truth. But for me to work, for me to have money in my pocket, I got to work, and I work hard.
All those toys, that is your working retirement. You work, but you also have your fun. That's what you're doing because you're a doctor and you feel that you have to be there for your patients and you can't retire.
Yeah.
So yeah, you have these toys, you enjoy yourself. I love it. I love that you can when you walk away from the practice on your days off or at your nights, you're out there. At nights, you're out dancing with your girl. On the weekends, you're flying, you're racing, you're doing all these amazing things. You're working retired. That's what you are.
Yeah. Listen, I've always had fun, no matter what. Even when I was in medical school, I went to medical school in Italy, so the land of having fun.
Right.
And I remember my father used to say that. He says we live. He goes, I learned through his family. His parents were born in Italy, and who were hard workers, and by going to medical school in Italy, you learn that the Italians they live to have fun. Everything else is secondary.
Yeah.
I remember we used to get up early in the morning, right? And we go to school, we go to school, we study. And then when it came around 12 o'clock, everything would close down. Everything. The operating rooms, you had a skeleton crew in the hospital. Whoever's on call that day was actually there, right? So it was like a weekend in the United States where nobody's doing surgeries and stuff like that. You just had whoever's on call at the hospital from 12 o'clock to like 4 in the afternoon, maybe 5. Like the surgeons would do surgeries in the morning, and then they check their patients out post-operatively right away, and they go home and have lunch and have a little wine with dinner, with lunch,
Right.
and they take a nap. They get up around 5 or 6 o'clock, then go back to the hospital and do rounds on the patients they operated on.
Right.
And then another day they would go to, they'd have their office hours early in the morning, 12 o'clock, done. Maybe at 6 o'clock at night, they would go visit the patients in the OR that they operated on the day before. And that's it. And when they did 1 or 2 operations in the day, I remember saying to one doctor, he said, you had all these patients you could operate on. How come you don't do them all tomorrow? He says, I do 2 operations a day. That's my quota. I do any more than that, it's too much. These guys don't die of heart attacks. They're not out there working their ass off to see how much money they can make and make as much money as they possibly could, like they do in this country.
Yeah.
Because they were making a good living. And I'm talking about the ones that had clinics, that private clinics where they didn't kill themselves. Like,
Right.
well, nobody kills themselves over there in Italy. You just live and have a good time. That's where I got it from. Yeah, I probably work a little bit. I'm by myself right now. You know what I like to put out there, and I hope somebody's out there listening that might be interested in an opportunity as a anesthesiologist, pain physician, an interventional pain physician. I am presently looking, and I decided this week that I want to find a good, young, hardworking, anesthesia-based interventional pain physician. Young is nice, but it doesn't have to be young, but they have to be devoted.
Yeah, looking to plant their feet.
They have to be devoted.
Yeah.
They have to devote. Listen, we're a bunch of good people over here at the Jasper Spine Institute. The opportunity is tremendous, right? Anybody comes as far as patients, other doctors, they come to learn. They love the facility. I got to find somebody that will work there and be willing to do some anesthesia and pain. The way I like to work it would be you never do too much of anything. It's nice to keep your hands a little bit in anesthesia, and I am there willing to share the work with the anesthesia.
Right.
For example, I'll do my cases that need anesthesia, and the other doctor will do their cases, and I'll do, and vice versa. We'll do each other's anesthesia.
Right.
That would be a great way of working. But they got to want to do anesthesia also. But if it gets so busy, then we just hire an anesthesiologist. But right now, in the beginning, I'd like to get somebody just to
serious-minded.
Yeah, serious-minded. Somebody that's a hard worker. It's got to be a hard worker. Go-getter. Pound the pavement, and make a good living, and get a fulfilling career by me.
Yeah.
So if anybody's interested, call the surgery center. You can call me. You can always get my number somewhere else. As a physician, you can get my number.
You can call us at the office at 732-262-0700.
732-262-0700. Give us a call. Let us know. You can talk to me, the front desk, Philip. He's hires and does all that stuff. But it's out there. If somebody wants that opportunity, it's a great opportunity.
Oh my God, yeah.
You know what I mean? Competitive salaries and by the way, we have a surgery center there. And a surgery center is a place where you can also make a good living.
Right.
I mean, when you get busy, or right from the beginning, it's available to buy shares in the surgery center.
Yeah.
And that's a decent income too for any physician. But it's got to be somebody that produces.
Yeah.
And you have to have that. And another thing I'd like to say, you got to be willing to live in the area. It's got to be within a half hour of the office. It just doesn't work.
Yeah.
I don't care who you are, who you pretend. You can pretend that you can do it, so live an hour away.
There's always going to be complications.
You
or
need
something,
to stay. Especially if you have a growing family.
Yeah.
I live 6 minutes from my office.
Yeah.
And it's been great.
It's a Jersey Shore. Everybody wants to live here. Come on.
Yeah, and it's a beautiful place to live.
Yeah.
You get a house on the water. You get a house in the country. You can get a house downtown. It's a nice area.
Yeah.
And there's a lot of surrounding towns that are beautiful.
Yeah.
So I like to put that out there.
So within 30 minutes.
Within
the
30
place.
minutes is okay.
Yeah, that's
Your
decent.
car's just warming up, and you listen to some
Yeah.
music. Sometimes if you let's say you're studying to be board certified, or you're studying to be instrument rated in an airplane like I did,
Yeah.
you got that 30 minutes to listen to YouTube videos, not watch them, but you can listen to different stuff and enjoy the trip. But an hour is too long.
Yeah.
So please give us a call if you're interested. I hate to get a headhunter. Headhunters doesn't really work that good. Sometimes it does.
Yeah.
But you got to pay them half the salary.
Yeah. I mean, there's young guys coming out of medical school, and they're looking to put their shingle up somewhere, and we're better than with the master of pain himself. My God, you will teach them everything you know. I mean, who wouldn't want to jump at that that chance?
Yeah,
If I was a doctor, I'd be leaping at it.
Yeah, especially most of them know me.
Yeah.
And the opportunity to come and learn all these minimally invasive spine surgeries and be independent. I mean, we're independent. We don't work. I don't work for anybody. And you come here, you're going to be part of the practice.
It's with the patients we got coming in, it's located in the mecca of retirement villages. Okay. I mean, seniors out the wazoo.
Well, some people don't like to hear that.
No?
Some doctors don't want to hear that. There are doctors out there that don't take Medicare. They want to take personal injury,
right,
workman's comp, and just out-of-network insurance, which is okay, But listen, I'm Medicare.
Yeah.
I hate to. I would hate if all the good doctors didn't take Medicare. I mean, what am I do? What am I going to do? Right. So that's not fair. I mean, but in the same token, Medicare in pain management today is actually, you can make a living, a damn good living, and most importantly, you can pay your bills.
Right.
Some of these people who have, work, personal injury, workman's comp, they got to go through hoops and loops and whatever you got to call it.
Big rigmarole.
Yeah. And then it's not necessarily the best thing.
Right.
You got to have connections. It's a lot of work, a lot of staff. Medicare is, except for the Medicare Advantage programs, the disadvantaged programs, that's a problem. But either way, you can make a good living. I'm making a good living. I'm not killing it, but I'm helping people. My satisfaction getting these people feeling better.
Yeah.
But we didn't talk much today about what we do.
We got one from the beautiful Gabriele Jasper. She says, last night I met up with a friend that sees Dr. Jasper. All she could talk about was how fantastic and professional he is.
Oh, yeah?
Yeah.
Well, thank you very much.
That's a great one.
I never slapped her while she was my patient. Huh? Never kicked her out of the office. She must be a nice patient. Everybody in the office was listening to that conversation. They all stopped everything and they were behind the wall listening to the conversation.
Right.
And which was good because everything that went on in that conversation, John, our relatively new nurse, he did a narrative on it. He wrote it down. Everything. He was pretty accurate.
Really?
On everything. She's definitely gonna give a bad review.
Yeah, Yelp's gonna hear from her.
She's gonna give a bad review. But you know what? It is what it is. You can't kiss people's asses because you're afraid they're going to give a bad review. But they were like, Dr. Jasper. There was one point I didn't even bring up in this conversation. She said, I don't like your tone of voice.
I'm going to tell you something. You're so calm with that particular situation. That blows my mind.
Well, that's what they said. They said, we can't believe you didn't throw her out right in that second.
You can get upset, but man, anybody else would have flipped out way earlier.
Yeah, well, I normally do, but I tried to stay calm now.
You're getting more mellow in your years. I'm telling you.
Well, what are you trying to say?
I'm just saying. Every day you get,
Listen, I don't want to have that reputation.
A little bit more chill. That's all I'm saying.
Yeah. Well, what are you gonna do?
But you can still bust. You can still kick some ass.
What are you gonna do? Lucky when she said that,
Yeah.
I didn't say, "Oh, listen, I'm Italian and I'm from Jersey.
Right.
That's the way we talk. There's nothing
Yeah.
wrong with the tone of our voice." But then that would have just then
Perpetuate things.
perpetuate her
Yeah.
later on about the Italians. I didn't even say that. Maybe that's why. She probably figured the reason I talk like this is because I'm Italian from Jersey.
That's so.
And that's what she didn't like about me.
I'm Scottish and I talk like that sometimes.
Well, you've been hanging around with Italians from,
Yeah, that's
Jersey.
right. I've been hanging around with you for the last 10
Yeah,
years.
last 10 years. So you started talking like me. But that's good. So what are you gonna do?
Yeah,
what are you gonna do?
What are you gonna do?
What are you gonna do?
Who
Hey.
knows? Who knows?
Sure. All right. So listen, I love to get rid of pain. At first I didn't really like it. I remember when I was an anesthesiologist and patients used to complain about things, and and the more they complained about their pain, more they complained about stuff,
Yeah.
the more of a pain in the ass they were, the faster they would go to sleep. And that was my motto.
Right.
If they were nice, told jokes, they stayed awake a little bit longer before the cases.
Yeah.
But now you would think, and I remember I said, I'm never going to go into pain in the beginning because I did some rotations, especially in those days they had nothing to do for pain. You would give them pain medication.
Right.
That was a pain in the ass. But as soon as they started coming out with the new stuff, then I started getting interested in it. And I went from saying I put them to sleep faster the more they talked,
right,
to now I sit there and listen to them. So I've have a completely different, because I know I can help them,
right.
And I sit there and I explain to everybody everything's going to go on.
No, I just for my own, just so you know, guys, I had a couple of operations over the last few months, and I had woken up with my foot not working. There was no pain; it just wouldn't move. And so then the next day I go see the doc, and I'm explaining it to him, and right, everybody in the office was like, "Wait, you don't feel pain?" I'm like, "No, it just it's foot drop," but there was no movement. And 2 endos later, okay, I have probably 95% mobility in my foot now. I can turn it all around. I can walk with it. I'm enjoying walking with it.
Yeah.
I walk my dog on the paths in front of my house barefoot, because I'm enjoying the fact that I got this foot that I can actually feel now.
It's
And
terrible when that happens.
but Doc, you saved that leg again, man. Thank you so much.
You're welcome. I mean, it's tough. Sometimes they just don't come back,
Yeah.
And there's not much you can do about it, especially with somebody who has no pain. When you got no pain, that's a bad sign.
Right.
That means the nerve could be dead.
Right.
But I think we gave you a shot, and it started moving a little bit.
Yeah.
Which gave us some hope, and slowly the nerve is regenerating.
Because I honestly thought after that second one that I would just be all right. It's a cane for me. Okay. But I know that like you can only fix something so much before it just starts crumbling apart. I mean that so I was well aware of that. But man, you pulled another miracle out of your pocket. Yeah.
Hey, listen, I just do what I know how to do.
Yeah, that's it. You can fix that.
Yeah. I can fix that. You got a loose step in your front, I can fix that. You got a squeaky door, I can fix that. All right, everybody. Well, it was a nice little talk we had today. Sorry.
Yeah.
I don't consider that negative,
No, it's more of a positive thing.
It's reality, really.
Yeah, we want you guys to be understand what's going to be going on for you, and get it done so we can get you out with no pain. That's it. We're not trying to.
And it's a process.
Yeah.
In my practice, it's a process. I have some patients come in and I say, "You're going to be a project. You're going to be a project. You have so many problems in your back.
Right.
It's going to take time. And if you don't have the patience," and I say this to every one of my patients that have quite a few pain generators. I said, in the beginning, I didn't have the patience for this,
right,
because I wanted it to work right away. But over the years, I've learned with patience, not giving up, you get to the bottom of it.
Yeah.
You can't give up. And then you finally find the right pain generator, where, like you said, a symphony of pain generators.
Hmm.
You know, you could have 5 pain generators that are singing at the same time. So you got to slowly eliminate one at a time. There's no shotgun where it's going to just get rid of them all.
Yeah.
You got to have patience, and it's not, there are doctors out there that milk everything.
Yeah.
That's not me.
Right.
That's not me. I'm one of the few doctors when you come to my office and you're 100% pain free, I'm happy. I'm sure there's more than a few, but you could look at it a different way, like a lot of doctors do.
Mm.
I just lost a patient. No, this is what I thrive for. The patient would come back with a big smile on her face, hug and kiss me, which happened at least 3 times this week.
And then you never see him again.
Well, you listen, you'll see him again for some other pain generator.
Right, right.
Why? Because we're getting older. As you get older, something else pops up. No matter, it gets you sooner or later.
Yeah.
It got me. It's going to get everybody. Got you.
Yeah,
it's going to get. I mean, you talk about job security. An interventional pain physician has job security, but when you can get rid of one particular pain generator, sometimes forever,
right,
that's a home run.
Home run.
And I do it. And then something else pops up. I get rid of that. You got to, and especially it's in a different area. When it's in a different area. Is Barbara coming in today?
Yes, she is.
She here?
She probably is. I have 2 more messages here for you, though. We got Christopher saying, thank you for sharing, and we all appreciate you immensely. And then we have Eileen Anderson. I am a project, and you never gave up on me. I have followed your plan for me, and I am so happy. Look at that. Yeah.
Thank you, Eileen. Thank you.
You got people, you got patients that understand, Doc. The ones that come in, I think a lot of them had a preconceived notion of how they were going to act before they even walked in the door, but the ones that really are in pain and need you, they know.
I have a couple patients, husband and wife that came in yesterday, and they say, Doc, we really look forward to listening to your radio show every Sunday morning. I say, you know what? This Saturday, I'm going to give a nice brand new show. It'll probably be in on Sunday morning, and I'm going to thank you guys for being my fan and coming. I told them I was going to bring them up. I'm not going to bring up any names because 2 reasons. Number 1, it's HIPAA compliant. Number 2, I can't remember anybody. I don't know which one's the most important one.
Right.
But I was going to bring them up for a particular reason, which I completely forgot what the reason was. But
thanks for watching, guys.
You for watching.
Yeah.
I told you I was going to bring you up. All right, good. Have a great day, great weekend. It's going to be a good weekend.
When's Thanksgiving?
Thursday.
Oh, okay. So we won't see you before then. So happy Thanksgiving, everybody.
Happy Thanksgiving. If we don't see you before Christmas, happy Christmas and all the other holidays.
Yeah.
All right.
You take care, guys. For more information about Dr. Gabriele Jasper and all the wonderful things we talk about,